Thanks for the summary, Matthew. So to recap, this is somebody with HIV-2 on dolutegravir, abacavir, and 3-TC who has some cardiovascular risk and is developing kidney disease. And so the first clinical question that we had was, in such a patient, what approaches should we take to ART changes when NRTIs should be avoided? So first, let's just summarize HIV-2. I know that this is information a lot of people in this audience are aware of, but especially for our newer learners, it's pertinent. So there are 38 million people living with HIV in the world, and it's estimated that about 1 to 2 of those million people have HIV-2. Now, note that this is thought to be an underestimate. Unfortunately, because of reasons we're going to outline soon, there are challenges in the diagnosis of HIV-2, and so we suspect that there are probably more people living with HIV-2 than we are aware of. And also in areas where HIV-2 is endemic, testing may not be quite as available. HIV-1 and HIV-2 are about 55% genetically different from each other, and dual infection with both HIV-1 and HIV-2 can occur. In the US, it's thought that about less than 1% of persons living with HIV have HIV-2. So where's HIV-2 endemic? And primarily it's in Western Africa, in the countries of Guinea, Bissau, the Gambia, Senegal, Cape Verde, Cote d'Ivoire, Mali, Sierra Leone, and Nigeria. And I'll note that this is a good example of the effects of colonialism. You can see that in countries that were colonized by Portugal, there are some connections there. And then where the Portuguese subsequently colonized other areas, such as Goa in South Asia, you'll see more HIV-2 there. But primarily it is centered in these countries, as you can see here. So what are some differences between HIV-2 and HIV-1? So one thing that's important to know is that the transmission of HIV-2 is thought to be less efficient than that of HIV-1. And it's thought that this is likely due to lower shedding of the virus in the genital region, as well as lower viral loads. There's also a longer asymptomatic stage of HIV-2 with a slower T cell decline, as well as, again, lower levels of virus in the plasma. So in one study from Guinea, with 23 years of follow-up, the median times to progression from AIDS from a diagnosis of HIV was 14.3 years in patients with HIV-2 versus 6.2 years in patients with HIV-1. And in another prospective observational study of 103 persons living with HIV-2 who were not on ART and who were followed between the years 1991 and 2009, their levels remained of virus in the plasma were generally pretty low. And actually up to 40% of patients in that cohort had a viral load of less than 100 copies per milliliter, and this is without ART. And I'll note that this is similar to what's been seen in other studies where up to 40% of patients, again, may have very low viral loads that are such that they're undetectable depending on the PCR being used. It's also thought that patients with HIV-2 may have a reduced CD4 count recovery with ART, although I'll note with newer data on the integrase inhibitors, this may not be the case uniformly, but in terms of prior regimens, such as PIs and triple NRTI therapy, et cetera, it's thought that the CD4 counts had lower recovery. So there are also some testing challenges to note with HIV-2. One is that there are limited HIV-2 antibody tests that are currently FDA approved. Really, in the US, the primary one is the Genius HIV-1/2 supplemental assay. And it's also quite difficult to get HIV-2 quantitative RNA testing in the United States. Multiple websites note that the University of Washington is a site for this, but most recently, when Matthew tried to get this test for his patient, he was actually told that they were no longer doing it. Both the CDC and the New York City Department of Health can do HIV-2 testing, and so these remain the primary sites. There's also a lack of ability to get resistance testing. Previously, the University of Washington was a site for this for research use only purposes, but again, there is some limitation at this point. The other thing that's challenging is, as we've noted before, that a fair amount of people with HIV-2 will have peripheral plasma viral loads that are below the limits of detection. And so getting an RNA only for HIV-2 is not enough to rule out this diagnosis. One can still have HIV-2 infection with a negative PCR in the periphery. And so now we're very fortunate to have Dr. Hibu Mostapa here at Hopkins, directing our virology lab, and we're even more fortunate to have her here to talk with us about some of the testing considerations for patients with HIV-2.
All right, I'm lucky. My part will be recorded. So thank you so much for inviting me today. This is actually like a hot topic in the lab because we are actually building a new test in the lab here. And I actually approached Matthew and Yuka to try to help me figure out the actual needs and how we can make this test available. But let me go quickly first through the diagnostic HIV algorithm. So in here, this is the current CDC algorithm recommended actually since 2014. So I think it's due for updates, to be honest. But this is what we currently do here in the lab. So when you have a patient suspected to have an HIV, or you are screening in general for HIV, the very first screening test is an HIV-1/2 antigen antibody combined immunoassay. And this is currently run in the core lab. If this test is positive, they actually run it again using the same assay in duplicates. And then if it's consistently positive, then they do run an antibody differentiation assay or immunoassay. This is the Genius test that Matthew mentioned. And the value of this second tier or second step in the algorithm is to confirm the first result and also to differentiate between HIV-1 and HIV-2. Optimally then you should get a confirmatory result and a differentiated result. So if it's like HIV-1, you should get an HIV-1 positive result and HIV-2 negative. Then you conclude that you have an HIV-1 infection. If you have an HIV-2, then you should get a positive for 2 and a negative for 1 and so on. And then in very rare occasions, you might get both positives, but then in some occasions we get indeterminate results or a negative result by this assay, which will be then discrepant from the first screening test. And in these occasions, we receive those specimens in the molecular lab to confirm the result with a molecular test. And in this part of the algorithm, all the testing has been only for HIV-1. So all the available testing for diagnosis was only for HIV-1 by molecular methods. The available, and because this is all based on what is FDA available, cleared assays that are available, and nothing really was available for HIV-2. So practically speaking, then you get a confirmatory result only for HIV-1 through this algorithm. Just included this here to show you what are some occasions when you can get a positive screening test and a negative confirmatory test, but a positive molecular test, because you have what is known as the window period here, where before you get your antibodies rising, you get there is the P24 antigen that is detected before the antibodies. And this P24 antigen is a component of the screening test. So sometimes you have the P24 antigen detected, but the antibodies are not detected yet, but you still get the positive PCR result because, of course, your RNA levels in the plasma are detectable much earlier than even the P24 antigen. Now, if we look at our numbers very quickly, so in general, with the very first screening, only a few turns out to be positive that needs a second confirmation with Genius. So our positivity rate in general is very small. It's like 0.7%. And then of those Genius results, we tend to receive maybe 37% of them in our lab for confirmatory testing with our HIV-1 test. And of those that confirm, it's still like a good percentage of those that end up being a primary infection with HIV-1. And then the assay that we have been historically using in the lab to use in that algorithm has been our quantitative HIV-1 test. And you can see here, this is just the intended use from the FDA package insert. This assay is actually was FDA cleared to follow up on patients already diagnosed. So it's a quantitative assay. We use it to give us a quantitative method. It was not actually FDA cleared as a screening test or for diagnosis. So we were really using it off the label kind of. We did like an internal validation, quick validation, but it was not in its FDA cleared intended use to actually use it in that algorithm. So just recently, the same company was able to have an FDA cleared HIV1, HIV2 qualitative assay that can now be used for diagnosis and can also be used to differentiate the two viruses in a molecular method. And it is also FDA cleared for diagnosis of neonates. So really, it has been wonderful to have this assay FDA cleared. And we finished validating the assay, and we are currently building the assay to be available to Hopkins to order. And this will replace this assay and that algorithm. So this will now confirm, so you can now have an HIV2 result if it happens that that the patient is actually infected with HIV2. So you will have a molecular HIV2 diagnosis. But as Natasha mentioned, and Matthew, that really the lower limit of detection relative to what you are expecting, like viral load wise in the patients, might be a different issue, but we do have an assay. Now, this is a qualitative method, so you will get a yes or no answer. So you will get an HIV2 positive or HIV2 negative. This will not solve the issue that you still have of wanting a quantitative method. As was mentioned, that the University of Washington's assay is about to really go away. I actually communicated with New York State. New York State, they developed their own quantitative HIV2 assay because New York is kind of one of the areas where they see a few hundreds of HIV2 positive patients. So they developed their own assay, and they actually are happy to have a contract with us. So we can send them the HIV2 quantitative orders or requests, but they actually are asking for a minimum of 10 patients because if we have less than that, they will not be able to have a contract with us. And they can't, we can't ask them to just run this assay for us for free because of different reasons. But this is an option, and we can actually work with them. We can't, unfortunately, bring this test in-house because it will be more expensive to run the test than to like have the volume required to actually justify bringing the test in-house. But this is an option, and it's actually doable. So this is all what I have to say, and I can answer any questions. And I will stop sharing if I can. Yeah.
Thank you, Hiba. So just to clarify, so the new COBUS test that's going to be in the algorithm, does that mean that if someone has HIV1, it'll just say positive, but then we'll have to order another test to get what the initial viral load is?
Correct.
Okay.
Yep. Yeah, this is one of the disadvantages of replacing the first test, but yeah, it will have to be done this way.
Okay.
So Heba, just one quick question for you about that. I would say that the CDC is not yet on board with this particular screening algorithm. They are considering it, but they have not yet come out with guidance around it because I don't think that they feel they have enough data. So just to say, this would be a lab developed test here at Johns Hopkins.
No, we are not replacing the Genius Yucca. We are just replacing. No, not yet. Yeah, I agree with you.
Okay, fair enough. Sorry, I misunderstood.
Yeah, sorry.
Just the COBUS is what's going to change.
Right. We will use the correct COBUS test for this algorithm.
Yeah, so sorry, I don't want to confuse the issue. I think you should just pretend you didn't hear the last 3 minutes. Then I think it's important.
Other questions from folks? Hiba? So from this group, do you need to know, like, would it be helpful to know how many people would, I guess we could maybe query the system to see how many patients with HIV2 were seen in the clinic.
Yeah, if you just can give me a 10, I can actually work on having a contract so we can resolve this issue.
Well, maybe even now, can we do a straw poll? Does anybody have an HIV-2 patient? They could just raise their hand on reactions.
Kristen has 2.
Oh, wow.
Matthew has 1. And Ian was telling me yesterday that I think Patty Bardish has a couple as well. Irene also has some. 1, 2, 3. Oh, they are Patty patients. 2, 3, 4. So at least 4 right now. And there's that, I mean, certainly the amount of providers represented in the clinic are not well represented right now. So I don't know if there's a way to query Epic for this, but we could also post it in Teams.
Yeah, let's see if we can post it in Teams and they can get in touch with me. That way Heba doesn't get a jillion emails and I get come up with a list.
Right.
Or you could message me in Epic under secure chat. That might be better. So you could secure chat message me if you have a patient, and then we can put that into Teams, and then you can secure chat me. I'm on pretty much every day, so.
Yuka, I put a chat in a little while back, but maybe it needs another go.
Yeah.
Just to ask the same question.
All right. Okay, no other questions about the testing, then we're going to go back to the case. Thank you so much, Hiba, for attending and sharing that with us. It's very exciting that we might be one of the few labs in the country that has the ability to actually.
Yeah, and maybe we will find our 10 after we start using the assay in-house.
Yeah, yeah.
Maybe we can diagnose 6 more.
It's possible.
Thank you.
Thank you. I'm going to go back to sharing my screen, but first let me pull up. There we go. Okay. There's that. Okay, great. So just to recap, we were chatting a little bit about HIV2 and the differences between HIV1 and 2, and just went over some of the testing differences. And so just a few comments on ART selection for HIV2 before we get back to Matthew's case. One being that, keeping in mind there's no FDA approved ART for HIV2. And so what we do, we extrapolate from HIV1 and the small amount of data we have regarding HIV2 from clinical trials. Things to know that in terms of NRTIs, there are different resistant pathways compared to HIV1. So for example, AZT and stavudine do not tend to select for TAMs in patients with HIV2, but rather for the Q151M. And actually, it does not seem that TAMs have much effect on NRTI susceptibility in HIV2. And it's thought that this is due to the absence of NRTI excision activity in the HIV2 reverse transcriptase, which has been shown in studies of purified enzymes. So that's one significant difference there. And then NNRTIs have intrinsic resistance in this. And this is because there are natural polymorphisms at the Y181I and Y188L areas that basically alter the binding pocket for NNRTIs in the reverse transcriptase enzyme. And so the virus itself is less receptive to NNRTI medications. Same for fusion inhibitors, there's intrinsic resistance. And then in terms of entry inhibitors, we don't really know what receptors the HIV2 is using, nor do we have any real ability to get profile testing in HIV2. And so Wrapup is not really a reasonable option. In terms of protease inhibitors, there have been several studies that have looked at efficacy here. And essentially, of the protease inhibitors that we may use nowadays, even though I don't think many of us are using lopinavir, really darunavir and lopinavir would be the preferred protease inhibitors. Atazanavir appears to have less activity than darunavir. And this is partially because HIV2 has some natural polymorphisms, again, that are associated with PI drug resistance. And it's also suggested that you may need less mutations to get PI resistance in HIV2 compared to HIV1. And Matthew's going to talk a little bit about integrase inhibitors.
Thank you, Natasha. That's a great overview of the drug classes. So the use of integrase inhibitors in the treatment of HIV2 is common, but the evidence base on which that's based is fairly slight. think it's fair to say. There are a couple of studies that are listed there. One, the Peterson study looked at using raltegravir, and the Zheng study looked at using an elbiterravir-based regimen in the treatment of HIV2, patients with HIV2. In terms of resistance, then I think the issue is that as Natasha's already mentioned, there are different mutation pathways in HIV2 compared to HIV1. So, for instance, in integrase, then the N55H or the Q148R, that will result in resistance to raltegravir in both HIV1 and in HIV2, whereas the Y143 pathway requires additional mutations, unlike in HIV2, unlike in HIV1. And then there is again some evidence that dolutegravir is effective in those with first-generation integrase resistance, and the study there is the French study from CID in 2015. Then looking at other combinations, and specifically looking at dual therapy with dolutegravir and lamivudine, and that was one of the questions that I had. And those dual therapy studies, so Gemini, Tango, and Salsa, they only recruited people with HIV1, and to the best of my knowledge, there were no individuals with HIV2 included in any of those dolutegravir lamivudine studies. So, as I've mentioned, there are two small trials. The first one, the raltegravir one, had 30 people in, and the elbiterravir one, I don't remember the number, but not much more. And then, we think historically about what we used to do in treating HIV2 was to use zidovudine, lamivudine, and ritonavir-boosted lopinavir. Unfortunately, some cohort studies in West Africa, and it's in Senegal where they do most of the high quality work, they suggest that there is a high failure with PI-based ART. And then the last point is that there are some pending studies, including a comparison of PI and integrase, and then an open label study looking at dolutegravir plus 2 NRTIs. Natasha, I can't remember who was supposed to do this.
I'll just do it. Yeah. So what does the DHHS say? Our golden book for HIV management. So essentially, they actually recommend an INSTI plus 2 NRTIs, not really based on a ton of data, but based on these two small trials that Matthew just went over. And then an alternative regimen is a boosted PI, either drunavir or lopinavir plus 2 NRTIs. And because there really isn't access to HIV2 RNA, most monitoring is done by CD4 count and clinical status. And one difference between HIV1 and 2 from a monitoring standpoint is, for HIV1, we can stop checking CD4 counts in people who are persistently suppressed with a count of 500 or more. But it is suggested that you continue to monitor CD4 counts in patients with HIV2 because disease progression may occur in the absence of an undetectable viral load, especially given we also don't have access to viral loads. And they also note that resistance-associated mutations to INSTIs, PIs, and NRTIs may develop in people when they are on ART. And unfortunately, there are no resistance assays approved for clinical use, which again, really limits the care we can provide these patients. And so it says, if you're having problems, call an HIV2 expert. Who that is, they don't say, or how to find them, they don't say. So just a Bacavir. And so are there alternative options can we use that we can use in this patient, given that NRTIs are off the table? PIs are on the table, but we may now need to avoid NRTIs in the future. And so now I'd like to open it up to the group and ask for people's thoughts. And Matthew, any other questions you had for the group?
No, not at this point. If something occurs to me, I'll say.
Great. Let me just also make sure. All right.
So I can chime in a little bit. So I have no patients here in Baltimore, although I had a couple actually in Boston. But I think that, you know, and Matthew, your patient has not had a viral load, is that right? They can't get testing?
Yeah, they have had a viral load. They've had a total of 5 viral loads over the last decade or so. And the 2 most recent ones that were done at University of Washington were both undetectable.
Yeah, so in my recollection at the time, so I will mention the first one just because it takes 3 seconds. So she was an HIV-1 and 2 co-infected patient who was an HIV-1 elite controller. And there's some old data looking at sequential infection with HIV-2 and then HIV-1 that it may lead to some improvement in control of HIV-1. But regardless, she actually didn't get treated during the time I was taking care of her. And the other one was a pregnant woman who had HIV-2. And at the time, we actually sent viral load testing to the Netherlands because there was a lab that was doing it there. And she was like low, but moderately detectable. But she did have active hepatitis B, which we were going to treat anyway during her pregnancy. So we ultimately opted to treat her. But we did actually treat her with atazanavir because at the time we had more data on it than darunavir in pregnancy, and it's so much better tolerated than lopinavir. And I think my thinking about it, which I would apply to this patient also, is that if your viral load is so low that it's like very hard to detect, probably things that aren't optimal for higher viral loads are like totally fine. So in your patient, I would probably feel very comfortable with dolutegravir 3TC.
Thanks for that, Eileen. That's great. Thanks for sharing those previous cases as well.
And I mean, just to point out what you're pointing out is that this patient has a low viral load. And so the likelihood that they would both fail dolutegravir 3TC is low, but also that they would develop resistance is also low given their prior low levels. And as far as I could tell from the data, you know, there's both comment that there's high amounts of patients with HIV-2 who maintain very low viral loads, but there's also comments on how, you know, fairly impressive resistance rates developing while on ART in HIV-2. And I couldn't find any data that actually looked at that based on viral loads and differences there. And I was curious if anyone in this group knew anything about that. Part of it seems to be that there are different resistance pathways in HIV-2, but I think the other issue is that a lot of the data comes from Africa, and PI-based therapy we know is associated with less adherence, et cetera, anyway. But I was curious that with low levels of virus, people still seem to be able to develop resistance in HIV-2. And I was wondering if anyone knew if anyone had looked at data to stratify by viral load and likelihood of developing resistance in these patients.
I think that would be a mutation rate question if there was like a difference in the mutation rate of the polymerase. And I mean, I guess also could be the flexibility of the viral structure itself to tolerate mutations. But I always kind of attributed that to like small studies with,
Okay.
But I don't know. I really don't. And I'm not the HIV-2 expert that you would call.
But it sounds like overall you wouldn't be concerned, Eileen, about new resistance in this patient developing.
I think I'd probably be more like Matthew and be more concerned about abacavir than I would be about resistance.
Matthew, can I ask you a question about your patient?
Sure.
I was wondering, are you concerned? We see this sometimes in HIV, even in suppressed patients where the CD4 count seems to inexorably decline. And in your patient, it continues to decline. So what are your thoughts about that?
Yeah, I don't know if whether Natasha, we can go back to, that slide. So the most most recent ones are actually, so from
Oh, sorry.
2018.
I was
Yeah.
reading it backwards.
Yeah, well, I very helpfully put it in reverse order just to confuse. But it's such a great question. You know, I currently am looking after somebody else who is perfectly virologically controlled, but CD4 count is falling. Their infectious workup is normal, but I think that person has it's got a bit of a spleen, and I think that they have an underlying malignant disorder. So the things I think about are TB, syphilis, and underlying malignancy when that happens.
All right.
I think that I think that this person would be fine on dolutegravir and 3TC as well. It's somebody who's extremely good at taking their medication, and I have no worries about adherence. I suppose the little bit of anxiety that I have is you know, if there were underlying resistance to NRTIs that just hadn't been that we're not able to detect because we can't test for them, then that would essentially leave the person on dolutegravir monotherapy.
Yeah. And there is some data that there may be more
Had been
transmitted.
TAF.
Yeah. Say that again, Eileen?
I would feel more nervous if they were coming off of a TDF or TAF backbone, but I just feel like abacavir is so unlikely to be the linchpin. It makes me feel a little better.
Great, thanks, Eileen.
I was just saying that there is some data that there may be more transmitted resistance with NRTIs and HIV2 than HIV1, but again, the issue is the lack of ability for resistance testing. I guess the other option, depending on your nerves, Matthew, which you had mentioned, was Biktarvy while you're waiting for, you know, if the CKD doesn't progress and stabilizes out, that would be another way to get him off of abacavir. But Eileen's suggestion of DTG 3TC is probably a little bit cleaner because you don't have to worry about that quite as much. Are there other regimens people would suggest? Would anyone feel like we should just leave this person on Triamac? We don't know what's going on with that abacavir anyway. Richard, as our abacavir large-scale big data guru, would you have concerns?
Yeah, well, you know, we've debated this, I don't know how many times. The data are pretty much all observational that suggest an association not only with MI, but with stroke. And, but the associations, except for one study, have all been pretty weak associations that have either barely been significant or weren't significant. They just trended in a certain direction. My feeling is that if you have a good alternative to abacavir, don't risk it, even though we're really not entirely sure what its risk is. And we very well may here. So I think that's the best I can tell you. I haven't seen an observational study done, the new one's done since the one we did in the NA Accord, which again showed a weak association with MI. But you know, he's approaching 10% on his 10-year risk. So I guess I'd be antsy about it too.
Richard, isn't most of the risk in the first 6 months after starting? I mean, I know I've been like saying,
yeah, except for one study. The DAD did a study where they showed a risk that extended out for years potentially. But yeah, and actually the NA Accord risk also extended out more than the first 6 months. The first studies that came out, the French hospital study and the one that followed that, showed a 6-month risk, but there have been other studies that have shown it could be much longer. So I don't know what to know there. None of them show a strong risk. I mean, if you were compare it to the risk of, and this person doesn't smoke. I mean, if you compare it to most other risk factors, it's actually a pretty weak one. But I guess if you pile that on other risk factors, you know, well, why do that? Even if you're not entirely sure.
So Matt, I assume you would have already switched to dolutegravir 3TC if you had easy access to RNA testing. And I guess, I know Heba already mentioned Wadsworth Lab and that she's in contact with them. I don't know if you've contacted them specifically to see if they would do an out of New York State patient. I mean, if you're in New York State, it's free to send a sample, but I don't know if you've contacted them or not. I think it's limited. I know that Natasha didn't put any PIs on, so atazanavir has
no one mentioned them, not because I don't want them.
Well, there's in vitro resistance for atazanavir, so it's not a recommended agent. And then darunavir, it seems like is a possibility. But I certainly have more confidence with INSTI than boosted darunavir. And then what would you could do boosted darunavir and dolutegravir, I guess, but it doesn't seem like, seems like that has more downsides than upsides.
Can I just ask, Chris, you were saying that you have more confidence in dolutegravir over darunavir. Is that for specifically in this situation or just in general?
Well, I am hardly an HIV-2 expert. I've only read the literature, unlike a number of people on this call who actually have taken care of this sort of patient. But just from looking at the literature, some of the things that you mentioned, very small studies and PI resistance.
Yeah. That's helpful, Chris. Thank you. So as you're noting, darunavir is on the table, but why? I guess if we feel comfortable with dolutegravir 3TC, why the darunavir? And then I think Matthew had also mentioned perhaps this regimen as well earlier. And then just remind people what's off the table are the NRTIs, and not that you would use Maraviroc here, but Maraviroc, and then atazanavir. Other suggestions or comments?
Well, thanks everyone for working this through with me. I really appreciate it. Natasha, thanks for letting me bring this case today. I'll talk with the patient about it, and we'll go through the risk benefit, and then I'll feed back at some point as and when that switch happens, and let you all know how it went.
Well, I'm actually going to force people to vote here just because I think that's fun and I like to do that. So I'm going to ask people to use your reactions, which are at the bottom of your screen. You should be able to hover over something at the bottom and see a thumbs up sign or a clap or whatever you want to do. So I'm just going to ask people, so how many people would leave this patient on his current regimen? So we have a vote, no votes for that. Or you can use the chat if you really want to make me look at too many different things at once. All right, so no one wants to do that. How many people would use Biktarvy? Chat or reactions? Wow, no one wants Biktarvy. Isn't that everyone's like favorite drug? No, okay. How many people would go to dolutegravir 3TC? All right, now I know people are paying attention. Okay, 1, 2. All right, so I'm gonna say 50. How many people would do boosted darunavir plus dolutegravir? Maybe a couple. All right, very reasonable option. And how many people would do boosted darunavir plus 3TC? That's a 0. All right, Matthew. So you can also tell them that everyone likes dolutegravir-3TC. The hard thing is going to be, since you don't have like longitudinal data on his viral load, you could switch him and his viral load may stay exactly the same, you know, and
Exactly.
who knows if it's because of ART or just because of HIV2.
Right. And I mean, I think that his sort of, this person providing their own control, the CD4 count did fall from like 1,000 down to about 500 in the until 2016, which is why Robin had started him on treatment at that time. So I guess the same thing in reverse could happen. That would be a way of monitoring.
Yeah. Yeah, that's a great point.
Natasha,
Yeah.
Kristen put to the chat about did the DAD also have a study on darunavir and cardiovascular effects? And yes, it did. And it actually showed a risk for darunavir that was about similar to abacavir. So
was that ever public? That was a CROI abstract, but was it ever?
it was a CROI abstract, and I'm almost positive they went on and published it. I'd have to find out where. But yeah, that was originally a CROI abstract. So just to keep that in mind, if you're switching off abacavir because you're worried about cardiovascular effects, there is at least one observational study out there that suggests darunavir may be as bad, if not worse.
More reasons. All right. Well, we're at time and I want to be respectful of folks' schedules. So thanks everyone for joining.
Natasha,
and thoughts. Yep, sorry, who's saying?
Natasha, before we go, I just wanted to.
Oh, I'm sorry. Yes, I'm sorry.
That's okay. I just wanted to